Please welcome to the stage past president of Anesthesia Patient Safety Foundation, Dr. Mark Warner.
Great. Thank you all for being here today. A couple points I'd like to make today, and one is how much I regret the fact that you're not going to actually get to meet Dr. Angela Enright today. With the pandemic and the fact she's out of British Columbia, made it extraordinarily difficult to move back and forth for her, so she's actually going to be presenting live, but virtually. And I thank Dr. David Hepner, the head of the ASA committee, for arranging that today, and David, thank you so much for doing that. But today's lecture is by Angela Enright, and she's a clinical professor of anesthesiology at the University of British Columbia. She's going to give the Ellison C. Pierce lecture today on anesthesia safety in an asymmetric world. Now, before I do that, though, I'd like to introduce the new officers of the Anesthesia Patient Safety Foundation. Dr. Dan Cole is the new president. Dr. Megan Lane Fall is the new vice president. And then the oldies but goodies column, returning Steve Greenberg as secretary and Doug Bartlett as treasurer. So just to introduce you to the new officers of the Anesthesia Patient Safety Foundation. Now, this particular lecture is in honor of Dr. Pierce, who I think many of you know by history, if not know him personally. Dr. Ellison C. Pierce Jr., MD from Boston, is known affectionately as Jeep Pierce to many. It's a name he acquired when he had a Jeep in high school as his first vehicle. In honor of his vision and unwavering commitment to patient safety, the Anesthesia Patient Safety Foundation, along with the American Society of Anesthesiologists, put together this named lecture. Dr. Pierce was the past president of the ASA in 1984. He's the founding president of the Anesthesia Patient Safety Foundation, and he's one of the past century's most influential patient safety advocates. Without Dr. Pierce, we would have patient safety lagging far behind where it is today. And he was a remarkable individual, and he really started the whole patient safety movement, not just in anesthesiology, but patient safety movement worldwide, and is responsible for organizations such as the National Patient Safety Foundation, and then setting some of the guidelines that led to the Institute for Healthcare Improvement and a whole variety of other organizations. So he was a giant in our specialty and influenced so much of what we do today. Now, we also give an award in honor of his name, and it's given for the best abstract in patient safety here at the American Society of Anesthesiologists annual meeting. Now, our winners are in Shanghai, China, and for the same reason as Dr. Enright, we're unable to get over and back. But I would announce that Dr. Wang and Dr. Zhang from Shanghai 9th People's Hospital at the School of Medicine in Shanghai were the winners, and they were selected for their abstract on deep learning-based facial image analysis, predict the classification of laryngeal view under laryngoscopy, and it was a prospective cohort study they did. So certainly congratulations to those folks. A plaque's being delivered to them, and they'll be recognized in the APSF newsletter in February. By the way, if you're in a giving mood, just think Christmas is around the corner, and we're coming toward the end of the year. Feel free to donate to APSF. You can stop by our booth. You can, right outside the wall here, we've got this little dip jar. It's really fun. You take your credit card, pop it in, and I'm shamelessly advertising for APSF here. Oh, yeah, thanks. What I'd like to do now, though, is obviously introduce today's speaker. And I'm proud to say that Dr. Angela Enright is the first woman to give this name lecture, and I'm very, very proud of that. Dr. Enright is an extraordinary leader in our specialty. She's a revered anesthesia patient safety advocate. And I mentioned earlier, she's a clinical professor at the University of British Columbia. She's a past president of the World Federation of Societies of Anesthesiologists. She helped establish the LifeBox and then its foundation. And we know what an incredible impact that's had. I see Dr. Hannenberg sitting here in front, also on that foundation, and the impact that group has had worldwide. She's been a recipient of Queen Elizabeth's Diamond Jubilee Award, the only anesthesiologist ever honored in that regard. And she has taught patient safety and obstetric anesthesia in many under-resourced countries in the world. Putting her money where her mouth is, and that is actually going there and doing the work and doing the teaching one-on-one in small under-resourced countries. So today's talk by Dr. Enright is anesthesia safety in an asymmetric world. And Angela, I hope you're going to be on the screen here shortly. There we go. Thank you, Angela.
Thank you very much, Mark. And I'd like to start by thanking Dr. Warner and the Anesthesia Patient Safety Foundation for inviting me to present this Ellison C. Pierce lecture on patient safety. It's a great honor and privilege for me to be able to do so. I'm so sorry that I can't be with you in person, but I'm grateful to the people who arranged that I could present from here in Victoria, British Columbia. I have no disclosures to make. Unfortunately, I didn't know Dr. Pierce personally, but I heard him speak on many occasions. And in his Rovenstein lecture, he talked about his early days in anesthesia, and they reminded me of mine. When halothane was our only agent, enflurane was just coming on the market. When our difficult airway tray included a stilette and a straight blade. And there were no such things as oximeters or end-tidal CO2 monitors. So things have changed and progressed enormously, particularly in high-income countries, but perhaps not quite so much in low and middle income countries around the world. Now, Dr. Pierce said in that Rovenstein lecture, the pursuit of patient safety in anesthesia has been the chief goal of my professional career. As Dr. Warner said, the chief goal of my professional career has been to improve anesthesia education in low resource areas, and thus by doing so, hopefully improve patient safety. When I was thinking about what I should say in this presentation, this picture was circulating widely on the internet. I'm sure many of you saw it. And it is a marvel of modern engineering, a highway that goes through mountainous territory in China. But I couldn't help contrasting it with a roadway that I took in a neighbor of China, that is in Nepal. I was traveling from Kathmandu, which you see with the little square, the red square, going to a mission hospital out in the periphery where you see the red oval. It was called Tansen Mission Hospital. And here's the road we took. And while I was there, something happened that left an indelible impression on me. A young man was working up a tree and he fell and suffered severe injuries. He was brought into the hospital with a flail chest, bilateral hemopneumothoraces. And they looked after him as well as they could, putting in chest tubes, giving him oxygen. But he succumbed to those injuries. And I couldn't help looking at his young wife and thinking about his family, and thinking also that if he had been in my hospital or yours, he likely would have survived. Another time I was working in a low-income country in French West Africa, just in the south part of the Sahara Desert. I was teaching about oximetry, and the audience was a group of non-physician anesthesia providers who had come from around the country, far and wide, to hear this. And at the end of the workshop, We gave them oximeters to bring back to their hospitals. And I also gave them logbooks so that they could record what was happening with their practice and that I could look at them later on. And here is a page that I came across many months later when I looked through the logbooks. It's in French, so I'll have to translate it for you. But here in the left column, you can see that 9 of the 10 patients were having cesarean sections. Unusually, they were all under general anesthesia, and that is unusual because in sub-Saharan Africa, most cesarean sections are done under spinal anesthesia. But for whatever reason, they were under general. I can't tell you what kind of general, perhaps ketamine, perhaps something else. But you can see in this column that only 2 of those patients were intubated. The rest had their anesthetics under mask anesthesia. Nevertheless, looking at the saturations, you can see that they were actually quite satisfactory. And looking at the outcome for the mothers, they have the designation B for bon or the French for good. So the mothers did fine. But look at the outcome for the neonates. 6 of the 9 have a designation MN. That says mort-né or born dead. In other words, 6 of these 9 neonates were stillbirths. I don't know if they were fresh stillbirths or they were old. I don't know what the cause was. All I can think of is those mothers who didn't have a live baby and of the anesthesia provider who had 6 of their 9 patients with stillbirths. Now, I believe that there is no point in having a human right to health unless we provide good quality healthcare. A landmark in global surgery and anesthesia was the Lancet Commission. This reported in 2015, and it consisted of what they called commissioners who were surgeons, anesthesia providers, nurses, financiers, economists, and they looked at everything to do with global surgery. And they came up with many key messages, and I've summarized them here. They found that 5 billion of the world's 7 billion people have no access to safe surgery and anesthesia when they need it. They recommended that 143 million additional procedures would be required every year in low and middle income countries if we were to reach an even low baseline of surgery. And they found that patients suffered catastrophic expenditure in trying to pay for surgery and anesthesia. It was the strong contention of the Lancet Commission that surgical care is not only affordable, but we can't afford not to do it. If we didn't provide surgical care and its access between 2015 and 2030, the loss to those low-income countries would be over $12 trillion, $12 trillion. So it was the contention of the Lancet Commission that surgery is an indivisible, indispensable part of healthcare. Now, they set some targets for 2030, and I've listed them here. And you can see that they look at access to timely surgery. They talk about the specialist surgical workforce, that we should have 20 surgeons, anesthesiologists, and obstetricians per 100,000 population everywhere. That we need to do a minimum of 5,000 surgeries per 100,000 population also everywhere, and that countries should be tracking that volume of surgery and tracking the perioperative mortality. The Lancet Commission spent a lot of time talking about first level or district hospitals, because these are important in the provision of service to patients. They should be within 2 hours of where a patient lives. And they should be able to provide what they call the bellwether procedures. These are basic level procedures, such as cesarean section, laparotomy, open fractures. And if they can do that, they can do most of the other procedures that would be necessary to provide a base level of surgical care. They talked about the delays that happen in getting to care. Patients themselves often delay a long time before they seek care because they're afraid of going to the hospital, or they don't know what the hospital can provide. They're worried about the cost. And if they do decide to go, then how do they get there? Transportation is not well developed often. There's rarely an ambulance service, and most patients certainly don't have personal transportation. And again, there's a cost involved. And once they get to the hospital, they may not get care for a long time. There can be many reasons for a delay. The hospital may be very busy. It may not do that kind of surgery. They may have a lack of personnel, lack of supplies, lack of essential medications. And so there can be quite long delays. Now, here are some facts which you may or may not know about anesthesia and surgery in low and middle income countries. About 30% of the global burden of disease is due to surgical conditions. That's quite a high percentage. More deaths result from surgery than from HIV/AIDS, tuberculosis, and malaria combined. Yet there are agencies that continue to believe that surgery is a luxury item that can't afford to be provided, and concentrate still on infectious diseases and public health issues, whereas the deaths are quite astounding. About 4.2 million people die each year within 30 days of surgery, and 50% of those deaths are in low and middle income countries, even though the amount of surgery done in those countries is a very small percentage of all the surgery done in the world. And if we were to do what Lancet recommends, add 143 million more cases per annum, we could bring the total deaths in low and middle income countries up to about 4 million per year. This graph comes from a letter in the Lancet in 2019 from the Global Surge Consortium, where they say that perioperative care is a leading cause of death. And if you look closely, you can see that it follows ischemic heart disease and stroke as a leading cause of death. And many of those deaths occur in the low-income countries. Now, I don't know about you, but I find it difficult to think in those big numbers of millions. And so I want to take you now to a small hospital in southern Uganda. This paper was published this year, and the authors looked at all surgical and obstetric admissions to the hospital, over 17,000 of them. And they noted 385 deaths. And if you look, you will see that only about a third of those were perioperative deaths. The other 2/3 were non-operative. Now, there could be lots of reasons for that. They could be trauma. They could be patients who didn't actually make it to surgery. I'm not sure. But they also looked at the perinatal deaths, and there were 9,500 deliveries with 462 deaths, of which 412 were stillborn. And this speaks to that page in the logbook that I showed you at the beginning. Neonatal deaths are very high in some countries. In the blue print at the bottom of the slide, you can see the maternal mortality rates for the hospital I'm talking about for Uganda as a whole. And if you look at the USA and Canada, you can see that the deaths in Uganda are orders of magnitude greater than they are here. Looking at the perinatal mortality that I mentioned earlier, you can see that there were various reasons for the stillbirth. Some are fresh, some are old, and the perinatal mortality rate in Uganda is many times higher than it is in the USA and Canada. Now, the Lancet Commission talked about the third delay. That is the delay when the patient reaches the hospital but hasn't yet received care. And these authors looked at that in Uganda, and they found that 95% of the cesarean sections were classified as emergent or urgent, but the decision to incision time was 4.5 plus or minus 5.5 hours. Now, you know, and I know that in our hospitals, an emergency section would be done within 30 minutes. An urgent section would be done within an hour or two at the most. And looking at non-obstetric surgery, 64% of which was classified as emergent or urgent, the decision to incision time was noted in days. Is it any wonder then that this is a Ugandan proverb? To be a pregnant woman is to have one foot in the grave. So let's look then at anesthesia-related obstetric mortality. And these figures come from a paper published in Lancet Global Health in 2016, which says that anesthesia is responsible for 1 in 7 maternal deaths in low-income countries, and responsible for about 14% of deaths related to cesarean sections. There could be many reasons for this. One of the reasons which is coming to light now is this failure to rescue. So if things start to go wrong, for instance, a mother with a hemorrhage, if that's not diagnosed and managed quickly and appropriately, the outcome is often very poor. So it's their conclusion that maternal mortality following cesarean section in low and middle income countries is about 50 times that of high income countries. Looking at surgical, non-obstetric and anesthesia mortality, we see that Bruce Picard and the ASOS study published in the Lancet in 2018 estimates that the 30-day perioperative mortality rate in low and middle income countries is estimated to be twice that of high income countries. It's even worse where pediatric surgery is concerned. It may be 100 to 200 times that of high income countries. So you can see that we have a lot of work to do and much needs to be done to improve things. This review article was published in Anesthesia in 2020. And if you look at the names of the authors, you can see there are surgeons, anesthesiologists from various groups, the WFSA, the World Health, universities, low income and high income. And what they were trying to do was to look at what might be a plan to address some of these issues. Column number 1 looks at access, and I don't think there's much that we can do about that. Column number 3 is this failure to rescue post-operatively, and I think there is a lot of work to be done there, but I'm not going to deal with that today. I'm going to concentrate on failure to deliver safe surgical and anesthesia care. And it is the contention of these authors that this could be minimized by establishing a patient safety culture, by having skilled surgical, anesthesia, and nursing workforces, by adhering to best practice protocols adapted for the local area, and by using perioperative risk stratification. So let's take a look at some of these. This is the Global Anesthesia Workforce Survey done by the World Federation of Societies of Anesthesiologists, or WFSA. It was published in 2017, and they were looking at who is giving anesthesia around the world. And if you go to their website, this is a map that you will see. And you can see that in the red, that signifies from 0 to less than 1 anesthesiologist per 100,000 population. And the orange from 1 to less than 3 anesthesiologists per 100,000. And then you can see that that covers sub-Saharan Africa, many parts of Asia, most of the Pacific, and many parts of Latin America. So it definitely is an asymmetrical world. Now, if you want to look at a specific country, you just click on the part of the map or the name, and up will come this kind of information about the country you're interested in. So since we started talking about Nepal, I pulled it up. And it has a population of about 28.5 million people with 235 anesthesiologists for a physician anesthesia density of 0.82 per 100,000 population. The WFSA maintains that the minimum anesthesiologist to 100,000 population should be 5. But most people would think that Nepal is actually doing quite well. And the reason it is because way back in the 1980s, Canada worked with the universities in Nepal to start an anesthesia training program. And it has grown, and they have been running it on their own for many, many years, but doing a very fine job in producing and retaining anesthesiologists. But it takes a long time to get the numbers you need. And Nepal, like many places, even Canada and the US, has a problem with distribution. Anesthesiologists like to stay in the cities, but out in the Kathmandu Valley, in the places like Tansen, there are no physician anesthesiologists. And so a new cadre has started in Nepal of nurse anesthesia providers. Here is Niger from French West Africa. They have almost 20 million population and 14 physicians giving anesthesia. Here's the US by comparison, very well off with a very good density of anesthesiologists. And here's Canada, well enough off, but not as well off as the United States. And I thought you might be interested to see Rwanda, because that's a country where the ASA and the CAS have been working together since 2006. When I first went there in 2004, there was one Rwandan anesthesiologist for 10 million people. And our two organizations have been working together with the Rwandans to run a residency training program in anesthesia. And it is doing well. There are still problems, but now there are over 30 anesthesiologists in the country. But the vast majority of the anesthesia in Rwanda and most other sub-Saharan African countries is given by nurse anesthesia providers. Now, I'm going to stop there and say that nurse is a very broad generic term used in this context. Some of the anesthesia providers are nurses who have taken training in anesthesia, but many are not. Many are high school graduates who have taken a course in anesthesia and then are sent out to the rural and remote areas to continue their practice. They can be called clinical officers, they can be called anesthesia assistants. They have a variety of names depending on what country you're in. And best term to use is non-physician anesthesia providers because it encompasses all. So let's look at the sort of education and training that anesthesia providers get. This survey was done in Africa. And what they found was that there were many different training pathways. Some countries trained only physicians, very few, South Africa, Egypt, and Namibia being 3 of them. Many countries trained physicians and non-physician providers, and some countries trained only non-physician providers, and finally some trained nobody at all. So a wide variety of programs and no generic curriculum, which I suppose isn't surprising since Africa is a big continent made up of many countries. But what they found was that only about a third have practice guidelines. Only about a third have standardized exams before entry to practice. And the length of training and the type of training is incredibly variable. You can see there for both physicians and non-physicians, the training is very different. Now, this paper, with many names in the authors list, consists entirely of surgeons. They went to look at the barriers to surgical progress in Malawi, Tanzania, and Zambia. And what did they find? They found that anesthesia was the rate-limiting step. There were staffing shortages. There were only non-physician providers, often untrained people giving anesthetics, no supervision. Anesthesia equipment was very often non-functional. There was a lack of suitable supplies, a lack of essential medications, sometimes even a lack of water and electricity. That more common in the rural areas than in the cities. Nevertheless, it was their contention that until the issues relating to anesthesia were addressed and remedied, that surgery would be unable to progress as it should. Unless you think this is only in Africa, here's a paper from Guatemala, where the authors looked at all the public hospitals in Guatemala. And you can see there's a variety of anesthesia providers. I have nurse anesthetist in inverted commas there because there hasn't been a school of nurse anesthesia in Guatemala since 2008. So there are many people giving anesthesia there who have very variable qualifications or have learned on the job. I think the thing that shocked me the most was seeing that 90% of the district hospitals reported that no anesthesia provider was continuously present during a general or spinal anesthetic. This on top of the issues of poor equipment, lack of monitors, shortage of essential medications. Now, the authors of this study used the anesthesia facility assessment tool made by the WFSA, and this is based on their international standards for a safe practice of anesthesia. The World Federation has been writing standards since 1992 and upgrading them every few years. But in 2018, World Health joined with them to produce this combined set of standards. And they're divided into various categories. There are some people who believe that these standards are set too high because of the unavailability of appropriate monitoring in many low and middle income countries. For instance, pulse oximetry. And although huge efforts have been made by Lifebox and by other groups to provide pulse oximetry where it is needed, there are still many without, and yet it is considered essential under these standards. However, the idea is that there is a low-cost oximeter available, and there should be a goal for these countries to be able to get it and to use it. End-tidal CO2, for instance, is not under the essential category. It's recommended, But because there is no model available that is cheap, easy to use, and sustainable in the tough environments in many countries, it's not made essential. But you'll be glad to know that WFSA, Lifebox, UCSF, Smile Train are working together to try to produce an end-tidal CO2 monitor that will be appropriate for use and of appropriate cost. Jeff Cooper, well known to all of you, wrote this in 1984. And as you can see, he talked then about all of the things I'm talking about today. And there have been many improvements in high-income countries, but there is a long way to go in low and middle-income countries. Now, in 2015, Ian Wilson and Isabel Walker, who are two consultant anesthesiologists from the UK, wrote this editorial. They are well known in the global arena. And they were feeling very optimistic. Why was that? Well, the surgical safety checklist was released in 2008. And although it hasn't been adopted everywhere, it has been fairly widely adopted, even in low-income countries. And it has been adapted for use. There's still a way to go, but it is a very positive step. There was a unanimous resolution passed at the World Health Assembly in 2015, making surgery and anesthesia essential parts of universal healthcare. That had taken years to accomplish. Lots of work has been done and is continuing to be done on national surgical obstetric and anesthesia plans. This is what Lancet recommended. And what these plans are hoping to accomplish is the breaking down of the silos between surgery, anesthesia, obstetrics, nursing, and the government to get together to plan how the 2030 goals might be reached by working together. It's my belief that many of the programs of assistance that are in operation today have improved enormously and are much more long-term and sustainable and a two-way street so that both sides benefit from it and have the focus on the needs of the low-income countries. And because of that, numbers of faculty are increasing. They're better able to advocate to their own governments for what they need, and their skills as teachers are also improving. And for those of us who produce programs of continuing medical education, we are starting to focus on multidisciplinary teamwork. So for instance, when I go to teach the SAFE obstetrics course, that is safer anesthesia from education, it includes not just anesthesia providers, but midwives and obstetricians. When we teach the SAFE OR course, it includes surgeons, nurses, anesthesia providers, all working together as a team, focusing on non-technical skills, focusing on communication, and how we can all do better when we work together. Now, this slide and the next, I borrowed from Dr. Janet Martin. This just is a look at how we are progressing towards those Lancet goals, which you see on the right of the slide. And you can see that we're making slow but steady progress on most of the issues. But then COVID arrived, and it has changed things enormously. The Gates report in 2020 said, we've been set back about 25 years in 25 weeks. And I think we can all understand why that is. If you think about the Ebola epidemic in Liberia from 2014 to 2016, the amount of surgery that was done then and afterwards had diminished by about 60%. The number of cesarean sections and deliveries done in hospitals had decreased by about 40%. So the impact on low-income countries is profound. And that was an epidemic. With the pandemic and its effect on healthcare providers throughout the world, who knows just how extensive the effects will be. So when I gaze into my crystal ball, what do I see? Well, I'm basically an optimist. I see the glass always as half full. And this is from the World Health Assembly. Now, the World Health Assembly is the goal-setting body for world health. And this talks about patient safety. It has nothing to do specifically with anesthesia and surgery. Nevertheless, it does talk about improving safety, at looking at clinical processes, at improving knowledge and information and education. So I think it is something that we can fall back on. This is an important one, and this is work done by the WFSA, working with, it's over 50 countries who are in the UN Human Rights Council. And there, they succeeded in getting surgery and anesthesia included in the strengthening of capacity and resourcing of healthcare systems and improving of training of healthcare workforce. This, I think, is a really important group of people. This is Global Health Research Unit on Global Surgery. And it started out in Birmingham in the UK with surgical departments around the UK working together on surgical issues. When COVID came along, they broadened their mandate to include not just the UK, but departments around the world to see what the effect of COVID was, what could be done about it, what was happening. And they have been extraordinarily successful in doing randomized control trials and producing data, which are important on COVID now, but will be very important in global surgical research and will give us the data we need to allow us to make changes. If COVID has done nothing else for us, it has speeded up the ability to get research projects approved, to get ethics approval, and to get them done and published much more quickly than we ever could before. So I think this is something that we will have to look out for in the future. And this African perioperative research group, in fact, is well in operation. It is led by Professor Bruce Picard, an anesthesiologist from Cape Town, who has done a fantastic job of getting and developing a network of African countries. I believe there are 45 African countries involved, and the participants include surgeons, anesthesia people, nursing, and they have produced work which has been landmark. The African Surgical Outcomes Study was published in 2018, and that's #1 in the African Surgical Outcomes Study. 2 is about to come out. And there have been many offsprings of these studies. So now we're beginning to get big, hard data on what is going on in surgery, in this case in Africa, and in the case of global surge around the world. And it is Professor Picard's contention that we can benchmark the outcomes in Africa, that we develop a holistic perioperative team culture, which he has already developed, and that we will be able to affect change by implementing quality improvement projects. And what's more, he's been able to do this on a shoestring. It is quite remarkable work and will have profound effects on our ability to influence outcomes in anesthesia and surgery. Dr. Pierce wrote that patient safety is not a fad. It's not a preoccupation of the day. It's not an objective that has been fulfilled or a reflection of a problem that has been solved. Patient safety is an ongoing necessity. It must be sustained by research, training, and daily application in the workplace. And I subscribe to that opinion. And I believe that if we continue to do what we have done in high-income countries and do the same in the low and middle-income countries, that we will have an outcome that looks much happier than some of those I've showed you, and generally much safer. Thank you very much.
Angela, thank you so much from all of us here. Extraordinarily proud that you have been the lecturer today, and thank you for the wonderful message you provided. It's exactly the type of thing we're interested in improving anesthesia patient safety worldwide. So Angela, thank you. Plaque is being sent to your home to recognize this. Now, you probably have 3 rooms full of plaques, but please add this one there. And in a couple of years, we have a team coming up. We'll visit you, and we'd like to see that room. Anyhow, for all of you folks in the audience, thank you so much for coming today, for your interest in anesthesia patient safety, and of course, your support of APSF. So thank you very much. Angela, have a wonderful afternoon. Thank you.